Good afternoon. My name is Gina Konstantakopoulos, and I am the Director of Marketing and Engagement at Matter. We are a healthcare incubator and corporate accelerator located in downtown Chicago. Welcome to today's event, which is Activating Allies in a Time of Crisis, the Monkeypox Response. This is a program that we are co-producing with two other amazing organizations, Chicago Innovation and StartOut, that you'll hear a little bit more about in just a few minutes. Before we get started, let me tell you a little bit more about Matter. Matter was founded in 2015 with the mission to accelerate the pace of change in healthcare, and we really do three things in service of that. First off, we help accelerate startups. We've worked with over 700 companies since 2015 who've received more than $4 billion in investment and are really making changes along all stages in the healthcare startup ecosystem. Additionally, we work with about 65 corporate partners to help bring innovation into their organizations. We do that through roundtables and accelerators, as well as really helping them keep a pulse on the industry. And last but not least, we are a nexus for community, and we bring together programs like the one today. We do that with small panel conversations and larger conversations like the one we'll have today. With that, I'd like to introduce one of our program co-leads, Luke Tannen from Chicago Innovation.
Thank you so much, Gina. It's great to be here. So Chicago Innovation is very proud to be part of this event, and I want to give a special shout out back to you, Gina, and your team at Matter, and StartOut, and Drew and his group for bringing great speakers together today to discuss an important public health issue. So at Chicago Innovation, our vision is to ensure that innovation is for everyone. And so that's why we know, today's topic is a really important one. And in particular, I believe it's important for the business community to be allies with public health organizations, and especially with their own LGBTQ plus employees and the greater community, as everyone plays a role in navigating this issue, as we will learn. And a great leader in both the business community and the LGBTQ plus community is serial tech entrepreneur Drew Stern. He's the person that I'm pleased to introduce next. So in addition to being a Chicago Innovation Award winner a few years ago for his company Esquify, which he then later sold, Drew's also the founder and CEO of Stagio, the world's first digital marketplace for stage performers to directly engage their supporters. And on top of that, Drew is very active civically involved in a number of organizations, including being a board member of StartOut, which accelerates the growth of the LGBTQ plus community to drive its economic empowerment and supporting all great kinds of entrepreneurs and being involved in events like today. And Drew will tell you a bit more about that. So please, Drew, take it away.
Thank you so much, Luke, and thank you all for joining us today. It's really a pleasure to see all of these really wonderful folks provide their time and come together to provide this programming. A special thank you to Matter Health, as well as Chicago Innovation, for partnering with us. This started off as an idea a few months ago, and I'm glad to see this all come together. As Luke mentioned, I am an entrepreneur, but I'm actually a volunteer on StartOut, who I'm representing today. StartOut is an LGBTQ focused entrepreneurship organization. We focus on bringing equity and inclusion to the startup process through education, networking, and general programming. Our marquee events are the Equity Summit and Demo Day. And while we are a national organization, we actually have chapters all across the country. So I sit on the Chicago board. So we also have local events in addition to our national programming. So for example, in November, we are doing a tea tasting at Eli's Tea Shop in Andersonville. So if you're able to join. We're also gearing up for next year and looking for board members. So if you are interested in LGBTQ entrepreneurship, please check us out online at startout.org. So it is my pleasure today to introduce you to this panel as well as to this idea. So this idea really started this summer when the LGBTQ community was really going through the height of this crisis. And we sat back and thought about intersectionality and the intersectionality of the community and allyship. And we thought, what a better way to have a conversation about this than pulling together folks from a business background and reaching out across communities to talk about authentic allyship, intersectionality, and how we can really show up when communities are in crisis. And this is really focused today on those learnings that we've had in this time. So with that, I want to give a very brief introduction to our panelists who will be introducing themselves. But today's panel will be led by Garrett Taliaferro. Garrett is the second vice president, underwriting medical professional liability insurance and healthcare at GenStar Insurance. He's also very involved in the LGBTQ plus community in Chicago and is a board member of Howard Brown Health. We're also joined by Kate Steinle. She is a nurse practitioner and chief clinical officer at FOLX Health, which is focused on telehealth for the LGBTQIA+ community. And lastly, we are also joined by Mark Liberson. He's the VP of the North Halstead Business Alliance. He's the chairperson of the Chicago Pride Fest and Market Days, sits on the World Pride Committee, and is also the owner of Replay, Lakeview, Replay Andersonville, Hydrate, Elixir, and many others. And thank you all so much, panelists, for joining us today. And I turn it over to you, Garrett.
Thank you, Drew. And first of all, I want to give thanks to StartOut, to Chicago Innovation, and Matter Health for putting this all together. I'm greatly honored to for the privilege of moderating this program. A little bit about me, as Drew mentioned, I'm in the healthcare industry professionally as a medical liability underwriter. Been involved here in Chicago LGBTQ community for over 20 years through various organizations, and currently sit on the board of Howard Brown Health. I will also let my fellow panelists introduce themselves, so I'll pass it off to Mark.
Thanks so much, Garrett. It's a pleasure to be here as well. I am the vice president at North Halstead Business Alliance, business owner on Halstead, having Replay, Hydrate, and Elixir there, in addition to Replay and Elixir in Andersonville. I do work with Interpride, which is the organization of world prides or prides around the world, and am also a board member of Howard Brown Health along with Garrett, and hopeful that we'll have some great conversation about what went down in our community today.
Everyone, thanks for joining us. Excited for this conversation. I am a nurse practitioner by training, and as already discussed, I'm the chief clinical officer at FOLX Health. So, you know, I'm here to kind of talk through some of the clinical pieces and just share some of the things that we have done as a business and as a resource in this country to kind of pass information on about monkeypox and how to both clinically take care of ourselves, how communities are taking care of themselves, and be a resource in that way.
All right. Well, let's get right into it. First question, Kate, if you can lead this discussion, what is monkeypox, and what is MPX, and why is naming significant?
Yeah, so just a brief, I don't need to go into all the clinical details, but a brief overview just to get people kind of up to speed on what monkeypox is. It's a virus, just like the common cold or herpes or COVID, and it is passed between people, just like all viruses. It causes a self-limited infection that sometimes can last, you know, rash or fever, chills, kind of make you feel sick for sometimes 2 to 4 weeks. And again, symptoms can kind of start after exposure, anywhere from a few days to up to 3 weeks after exposure. So very different. I mean, there's some differences, and we can go into this about other viruses. Like, obviously, we're very familiar with COVID. The difference here is that monkeypox is harder to get, harder to transmit than COVID. And it is not fatal, right? In most cases, it is not something, it will make people feel sick and it can cause really painful sores, but not something that usually causes fatality. So those are some big differences. And again, viruses span the gamut of mild to very dangerous. And so those are the things that we'll always like to keep in perspective as we're thinking about response and education around this. and just like other viruses, they can be spread in a variety of ways. So specifically, monkeypox can be spread mostly, at least the viral outbreak that we have in this country that we've been experiencing is skin to skin contact. So people who live close together, who share a bed, or, again, have sexual transmission through this. So anything where there's close personal skin to skin contact. It might also be spread by things like bed linens or sharing a towel. Those are kind of what we call fomite transmissions, where it's not actually skin to skin, but it could be something that's shared in those viruses passing through. So it's, again, the thing that I always find really helpful when we're talking through this to give education to people, because when we talk about a public health crisis, we want people to be aware, but we really want them to be aware of where the risks are and what the things are that they can do to either protect themselves, keep themselves safe, and educate other people about it. So really talking about transmission is super important. And then, in terms of your other question, Garrett, the actual term and MPX versus monkeypox. So monkeypox is that nomenclature that was made. This is not a new virus. So this was a name given to this virus. I think it was back in the 70s. When it was first around. So this is a virus, again, not new to epidemiology, new to us here, where we're like, wow, this is an outbreak. Has anyone ever heard about it? And it is actually the first time in the US that it has actually been spread in a pretty dramatic way. There was an outbreak back in 2013 in this country, but it was a pretty minimal outbreak and really focused very, very in a small spot, and so didn't spread as widely. The naming of this is actually one of the things to know is the WHO, which does the naming nomenclature for all of these viruses and diseases, is actually under consideration right now to rename this virus. What they have done as of August is actually rename the subvariants, what they call clades, with Roman numerals. And so the actual subvariant, and so we can call it by its subvariant if you want, it's clade 2B, which is the one that's most prominent in this country. And that is actually previously known as the West African clade. And so they've renamed the clade because the renaming of all of these diseases are actually making there's a new naming process, right? That was not in effect when this virus first came out. And the new naming process is for a bunch of reasons. And again, the clades have been renamed. The WHO is still under process of renaming monkeypox in general. Some different departments of health are going by MPX or MPV to go forward with that. Like California DOH has already done that. But really the renaming that's happening at the WHO level is to avoid any offense to any cultural, social, national, or regional or ethnic groups, so that not to associate a name of a virus with a group of people or an area. And also just to limit any negative effects on travel or tourism to that area, so that people don't always associate that virus from where it might have originated. Is not one, we want to take a blame away from an area. We want to take a blame away from people or a community, and really just name the virus for a different kind of naming structure. So that process is in effect, but again, right now the subvariants have been named differently.
Okay, do you have any idea, or can you speak to how long that process typically takes in terms of renaming, or does it depend on?
I think I don't know. I think it's there. The pressure is out there. I can say that. And so, they moved somewhat fast for multi-government agencies that they rename the clades. I don't know how long it's going to take to get to a new naming of monkeypox itself, but I think a lot of localities are actually going ahead and doing that themselves. Again, like I actually looked at the Chicago Department of Health. They're actually going with MPV. So there's other places that are already kind of taking that on. I think we know kind of when you get into larger structures, there's that behemoth kind of takes a while to move things and to get everyone to be in agreement. But I think the process here is how can we do that locally or even on a national level or locally, in our own departments or in our own communities.
Thank you. Next question is, can you provide sort of an overview in terms of sort of the cases? And also, if you can, also provide sort of context versus COVID versus sort of MPV, monkeypox cases, whether it's national or whatever data you can kind of share.
Yeah, definitely. So the CDC actually updates this every Wednesday. So we are perfectly in time for new updated data that I just got yesterday. Global. So again, we're talking just about this current outbreak, knowing that there has been outbreaks many times in Africa that we're not counting in this. This is the global outbreak of this current iteration. And that's about 70,000 confirmed cases of this virus. In the US, and I'm just going to look at my notes here so I can get the right one. In the US, as of yesterday, there are 26,311 total confirmed cases. And again, those are positive tests. And then in Illinois, there have been 1,329, again, as of yesterday. So when we do the math, that's about 5% of the total confirmed US cases. And most of the time, and especially in Illinois, same issue, is that they're condensed in higher populous areas. Viruses love when people live together. They are easier to transmit. And so that kind of obviously is very connected to higher density populations. I think that one of the things, and again, I'm happy to provide this to people afterwards, is one of the things that we are seeing here is both that the impact to the particular community, what we consider in a medical world MSM, or men who have sex with men, that this community was the most affected by this outbreak. It was spread widely, and that is continuing to show that there's no widespread outbreak outside of that community. So we can talk a little bit more about what that means about diversion of resources and education and how we make sure that the community that's most affected is getting the needs met that they have without any kind of being ostracized or anything that we can go into that a little bit more as we go through. But yeah, I think that the cases are on a decline. There's been a lot of amazing education, and we can talk about this, what the community has done to be able to educate themselves, in terms of being able to take care of their own, which this community that is mostly affected by MPX has always historically done and has done in this case as well. So that the decline of cases is happening. And, the reality is that it is probably endemic to the US now. We will have monkeypox around, but the decline in cases is showing a continuation. It might not be eradicated like it happened back in 2013 when we had the outbreak, and it was a very small outbreak. There's a whole bunch of reasons. Why is it that we didn't catch it fast enough? Why are the public health responses not fast enough that made this happen and blossom in a larger way than we had in the past?
Thank you. I'd like to sort of center the next portion of the conversation in terms of sort of screening, outreach, vaccination, and treatment, and Mark, from your perspective, from a business perspective, what has the response been, what has the outreach been, and how has the approach evolved and changed since the beginning, in the middle of the summer till now?
Well, it certainly has evolved. Initially, first, we were not sure what we were dealing with. We were hoping that we weren't going to be dealing with something that was quite as easily as contagious as COVID. And we were given a little bit of misinformation by the media in terms of what the presentation of the infection, how it appeared. Most importantly for us was trying to figure out, how do we protect the community and how do we continue to live our lives? Nobody wanted to go back to a point where we were having to add new restrictions or at least to add as few restrictions as we need to keep people safe. And what we did was we did what we do very well, at least in the LGBTQ community. We partnered with the local health department as well as our local health organizations like Howard Brown, where Garrett and I are both on the board, that have existed and been serving the community since the HIV crisis began. And I think that comfort level with relationships with a local health department that has sensitivities for the community really made a huge difference in our ability to respond. And our goal was to protect people. Initially, that was a little bit more challenging because while the good news was there was an effective vaccine, so that made it one step ahead. The bad news was that it wasn't widely available. And so we knew we could treat it, or that we could prevent it from a vaccine standpoint, but we knew that we didn't have the vaccines to do it. So the community decided to engage in an education effort. We figured that since we could not actually protect people with a vaccine, we needed to give them the knowledge that they would need to understand how to avoid exposure. And what we learned very quickly was that significant percentage, over 90% of cases, were being transmitted from intimate contact, from people having close, extended, intimate contact. It wasn't happening from casual contact on a bus. It wasn't happening from casual contact in a train or walking in the grocery store. And that was really important because we needed people to understand not only how it was that they are getting it and how to avoid it, but how not to be afraid, because stigma can result very rapidly. And if people are perceiving this as being a gay virus, it does have a lot of haunting images of the HIV crisis at its onset. And nobody really wanted to have a true viral infection that has existed long in the world and had nothing to do with the LGBTQ community suddenly become identified as an LGBTQ issue. While it has been centered in the LGBTQ community, the community didn't need to be fearful of or people didn't need to be fearful of members of the community simply for that membership. And unless you were going to be having intimate contact with the people in the community who might be infected, you ran a very low risk of any possible chance of exposure. So we really focused on education at the beginning. We did videos that we were showing in businesses. We had flyers, we had posters. We were very active out front on saying, here's what the virus is, here's what you do to avoid getting infected. And we also made resources available for people to get vaccinated easily in the community, although I guess easily is probably not the right word considering how restricted supplies were, but it was available in the community, proximate to where people were either living or where they were socializing.
And
Go ahead, Kate.
oh, sorry. Yeah, I think, Mark, exactly what you're talking about is how to focus on a community that actually is most affected without stigmatizing that community. And I think that's the piece where it's like, we got to get this right so that people are not scared of an identity or scared of a behavior, but like protecting against a virus, right? Like a virus is the thing. It's not the person. It's not, it's not like so I think that's the piece is we want to actually make sure that the resources that are needed for a particular community from a public health perspective, when they're limited, that they're going to the right community without, and how do we do that in a way, and it sounds like you all did an amazing job locally, like how do we do that in a way that provides the most accurate information, because that's what's going to decrease that kind of temperature and that fear and all of that.
And Kate, one of the things that you do make me think about is that initially the images and what people were understanding the virus to be about reflected what was going on in Africa. And this is actually a different strain of the virus. And so the symptoms that people were trying to identify were not true to this virus. The actual initial onset has very different symptoms. It's much more mild. And we had to educate people to understand what the initial symptoms were so that they could self-identify. We had to make people aware what to be looking for in people that they may have as partners to be protecting themselves from possible infection. And we needed to make people aware that that the virus had specific methods that were being most common in transmission. And by making them aware of what those methods were, we were hoping that we could allow them at least to make an intelligent choice in their behaviors to protect themselves and hopefully keep the community healthy.
Right.
Kate, it's before we move on to the next segment, like in terms of sort of the vaccine itself, is it readily available? Is it readily available to, say, business owners with employees? How is the supply? I know in the beginning there was shortened supply, and then there was a big ramp up. And so just wanted to get your opinion and thoughts on that. And Mark, you can weigh into from your business perspective.
Yeah, the vaccine is much more available now. It's still, if we think about, let's put it in a perspective of like what we went through with the COVID vaccine, right? We went through those stages of, at first, it was just for people who were, I think the age was like over 65, because those were the most immunocompromised, or the communities that we saw the highest risk and the highest fatality when they had that exposure. And then we went kind of like, as that vaccine became more available, those stringent kind of guidelines of who to offer to and who not to offer to became a little bit wider. And so we see the same thing now with monkeypox vaccination. It's not widely available for everyone yet. We're not at that place, but I think the piece here is, again, what Mark and I are talking about is like, how do we identify, again, the highest risk and the highest need population when we have a limited resource? How do we direct them to those resources? And how do we make sure that, that we want people, when there's limited resources, we want the people who actually have the possibility of having this transmission happen, have access to that vaccine. So yeah, I think it's going to continue to, as we see the decline, I mean, the decline in cases is due to the rise in vaccine and due to education, right? Both of those things are aligned there. And we're going to continue to see that decline. Again, hopefully that's the direction that everything's going, but that doesn't mean we're going to stop having vaccination. We're going to, from a public health perspective, we always want to keep that vaccination there, because that's what is leading to, again, that plus education is leading to that decline in the transmission. So, there's a lot of right now that people have kind of got their feet under them and know where vaccine is available. There's a bunch of different, each area has their own vaccine access websites, right? I saw on the Chicago one, there's places that there's numbers to call, where can you go? And all of that information is going to have in that locale what the requirements are, and who's being offered that vaccine, and up to date on who that is. So it might be based on each area of the country has a different supply, and each area, sub area within that is going to have a different supply. So you have to kind of do that same assessment of the current state and where you currently live, based on the access. But it is increasing, but that is a good thing, and it doesn't mean that it's gone away, either the virus or the access to the vaccine.
And I think the other good news is that, again, we're so used to thinking about COVID, that COVID is a virus that is mutating and continues to evolve. And this is a different type of virus. This virus is not actively, aggressively mutating, and the vaccine is therefore not needing constant reformulation. And so we're in a much more stable, it's a much better position. And I know coming off of a crisis like COVID, a lot of people became very fearful that, oh gosh, this is going to be the next COVID. And it's really a very different virus. COVID was an airborne virus, easily caught. And one of the biggest challenges that we faced on the education front is that as a scientist, scientists have very hard time saying something can't happen. So they will create a list. And I saw some of the posters initially that were created that had a laundry list of ways that you could catch this virus. Now, if you actually talk to the practitioners, they would tell you that that's a really great list. And yeah, those all seem like things that could happen. But if you ask them what they were seeing, it's a very different list. And that's a really important issue, because communicating effectively really requires to not only focus on science, but focus on practicality and what it is that's actually occurring in the community. That laundry list of possible ways of getting infected only could create fear, because it included airborne transmission. And that was not what they were seeing. So I think it's really important that the community here in Chicago actually produced materials that pulled back from the broader scientific definition of the world of possibilities and focused in on the practical definition of the experience and what was being seen in the clinics at this moment with this version of the virus. And I think that was part of why it was effective.
That's an amazing point, Mark. And I nod my head a lot, because that's often what I deal with in clinical practice when I'm talking with clinicians and leading them through any new thing, right? When they want to talk about a one particular time that they saw this one thing that happened, but that one particular time might have meant something important to them. But in terms of the data that we see out there as an entire clinical practice, in terms of, yeah, that one time that one person got, I'm trying to think of what like they had that random lab after they took Tylenol or whatever it is. We can't create a practice around fear tactics with one, like this is a very small percentage. We have to put things into perspective in order to offer people really clear information. Sure, there's risk out there for everything, but if we want to look at that in terms of actual clear assessment of your risk, I want to tell you from a top to bottom, what is the highest risk activities that people can engage in, all the way down to the bottom. And if you are somebody who really needs to know all that information, please go for it. But I'm going to focus on those top ones so that we can make sure that people are getting the information. And again, fear-based education is just that. And it's only going to make people not understand things, right? Not understand their real risk. It's only going to make them feel separated from each other, because they're like, well, it could be that. I've heard that it could be that as well. And how do we actually engage with people and give us, like we are all in the world right now, all about fake news and things coming from all these different spots. We actually need to be the providers of information that actually give clear information to people so they can assess their risk. And I do that with anything that I'm talking to a patient about. And, I'll just bring this into another piece that I often go through is when I'm doing a sexual health history with somebody and maybe assessing their need for PrEP, an HIV prevention medication. I'm talking to them about the highest risk ways that they could access or that they could get transmitted from HIV. And I'm not talking about those low risks, because that's very, very minimal way that they could get that transmission. So really being clear with those percentages of risk.
I think that, and thank you both. I think that ultimately it's, as I said before, sort of three parallel sort of silos or tracks that we're talking about. And to that vein, if you can speak to sort of screening and outreach is a big key component that goes within sort of the educational part, but then there's the vaccination portion and then there's the treatment portion. And so how does that all of that compare with the current MPV versus COVID response and flu vaccinations, and even to a lesser extent, sort of the HIV/AIDS epidemic? If both of you can speak to that, that would be great from obviously healthcare perspective, but also from the business perspective.
Yeah, I'll just do a quick overview of the treatment. So we've talked about transmission, we've talked about vaccination, and then treatment. So because monkeypox in this country, the strain that we're actually working with, or the clade that we're working with here, again, is doesn't have a lot of intense symptoms. The painful lesions are really the things that people are most affected by, right? There's the fever, chills, like kind of those flu-like symptoms, and then there's painful rash and lesions. And so the treatment, there's a couple different things that can happen. One, vaccination after exposure is one way to help minimize people's risk, or at least minimize the effect that that virus, if they were exposed to it, would have on their body. Most of the treatment that we're seeing right now for people who are, again, kind of fall in a healthy category and are not immunocompromised, or who don't have long-term illnesses that could lead to higher risk, is really the treatment is for pain relief and comfort measures, right? So you're, removing yourself from possible transmission risk to other people. So you're having some quarantine at home if you have active lesions, and pain relief medications. So that could be because the lesions are actually quite painful for some people, depending on where they've been exposed and where those outbreaks are. So pain relief medications are a big thing. There is a smallpox treatment that is out there that can be used. It's not that frequently used. Again, it's more one of those things that it's used for, again, is those higher risk populations where, when exposed and when you have when you've been diagnosed with monkeypox, that if your immune system is immunocompromised, you might want to take this additional medication. So TPOX is the abbreviated version of, or abbreviated name. It's one of those medications that is not FDA approved for the treatment of monkeypox, but it has been shown in some studies to help. So that's where we are with that.
Yeah, and I think that this is, again, where I do see a parallel to some degree with HIV, because while TPOX is not approved for treatment, I've known a lot of people now at this point who've taken TPOX because they were getting, these pox can not only occur externally, they can occur internally, affecting breathing, swallowing, etc. I have not heard of anybody not having an effective response from TPOX. Everyone has told me that it's had a rapid and just huge impact. And I can tell you that talking to the doctors, it's also had a huge impact on them, because the amount of paperwork that they have to create to be able to prescribe this very effective treatment is absurd. It literally takes them an hour of clinical time to complete paperwork, to provide people with the medicine that has already been, while maybe it doesn't have all of the experiments and everything done to document that you would normally do when putting a medicine into the public, it has been proven to be effective. It has proven to be safe so far in its use, and they are still making it extremely difficult on the medical community to benefit from that. And I think a lot of people are being denied access to that, especially depending on what community you're in. We're in Chicago, and we have an LGBTQ oriented health center that has become quite good at treating and getting people access to this medicine, even though it's taking an incredible amount of time out of a clinician's day. That's not happening on a widespread basis. That's not happening in small communities. That's not happening in less educated members of the medical community who may end up encountering a member of the LGBTQ community who's been exposed, who's infected, and who needs help. And I think that that's where we are still having opportunity for improvement. I think we can really grow as a community in terms of how it is that when we do find a medicine that may be experimental, that we're not 100% certain about, but that we have proven already has a track record of being effective, to make it more easily accessible. Some doctors may just not want to prescribe it just simply because they don't have an hour of their life to dedicate to fill out a form. That's a bad situation to put a very vulnerable patient in, where they're going to be denied a potential treatment simply because someone has to fill out so much paperwork. And that disturbs me. So I think we still have growth opportunities here.
Yeah, that's true. I was about to say nicely, they have decreased the amount of paperwork and made it a little bit more expedient.
I heard it was an hour and a half initially. Now it's down.
And then it's an hour. Yeah, I think, it's paperwork is not ideal. You no longer, there was you had to upload photos. There were some things that had to happen that they've now taken out of those steps. But yeah, it's not the easiest process.
And if you stop and think about it contextually, again, you have so many people who have this need. You have a limited number of resources of doctors. Every time you pull a doctor out for an hour, that means that other people are being denied service that they need, and you're really creating sort of a bottleneck in the medical community. I think that we have lessons still to learn, from HIV, from how it is that we address new infectious diseases and utilize what appear to be effective resources in a manner that makes sense, that is practical. And so I'm hopeful to see that continues to be, as the public health community and our national health community is thinking about what they're learning, that this is a lesson that somebody will begin to pick up on and hopefully move forward with. Because from what I understand, even at this point, we're how many months into this virus? I mean, that we are still at this point where it's an hour of paperwork for a doctor. I think that's just not acceptable.
Totally agree with you, Mark. And to that sort of point of terms of concerns about the most recent epidemic, one of my concerns is complacency. And another concern that I have is the sort of stigma of, especially particularly those in the LGBTQIA community, that it is just a gay disease or a gay problem. And so that goes out to sort of the outreach piece of allyship with some of our friends in the business community and just in the community, Chicago community in general. Kate and Mark, what are your concerns regarding the most recent experience with MPV? And do you have any sort of solutions to address some of those concerns?
Yeah, I mean, I think you touched a bunch on it, Garrett. I think we've all talked a little bit about the worry that we've had specifically about how this actual virus was talked about in our community or blamed in our community. Mm-hmm. And I think, in terms of that anytime there is a stigma associated with a health issue, we know what happens is that people do not access care. And it's already a community that feels, that historically and current day does not have trust in the healthcare system, right? They, for good reason, they have been blamed, they have been not heard, the intake forms that they are shown or the ways that they're referred to in a health center are not affirming to them. And so anytime there's like a little, sometimes there's a step forward, and then when there's multiple steps back about an actual virus being blamed for from a community, that is my concern. Is anytime there is what we try to do at FOLX is really care that is actually empowering, like healthcare that you want to engage with because you feel good about yourself when you are engaging with it, because the people in front of you are making you, helping with that empowerment process. Whenever there's something in the medical field where it's the opposite of that, where it's really about like making you feel internalized because something that you did is wrong, or that somebody is having some judgment about that, it takes a step backwards. And that is both a concern that I have as a clinician for individual patients, and a concern that I have from a public health perspective of being able to, like, anything that's in a shadow is going to fester and create more of an issue going forward, again, for the public health. So, I think that the ideal situation that we get to is a place where we are, again, exactly what we've talked about in this conversation. We are actually talking about the realistic risks, and we're actually talking about the thing that we need to attack, which is a virus, not a group of people, not an identity, not anyone's behavior or choices. Like, again, making something about somebody is choosing something, therefore they get something. Like that whole blame idea is the opposite of good healthcare. And I think that it is what my ideal for healthcare is in this country, which is, again, you feel comfortable enough as a patient to talk about whatever is going on for you in your own life, in your health life, in your what's going on in your body or in your relationships, without any concern that the person in front of you is going to have anything but compassion and a feeling of like a way to get you to a sense of agency. We're not there yet, and I think that that's part of what we need to do in terms of, this is about medical school training. This is about our healthcare system in general, which is very much this kind of top down. I am the, and this is, I can speak as a nurse practitioner in this way, and I love doctors. I have some really great friends who are doctors, and I work with great doctors. But in that doctor-patient world, it's often like, I am the one who knows. I will pass down that information to you, instead of this uplifting and partnership. And that uplifting and partnership is really like, again, what happens where there's change in terms of positive health outcomes on that individual level, and change in our communities when we actually are engaging in that way.
And I think that's really where it comes down to the importance of having allies, because if you stop and think about it, the alliance that we had between the business community and our local health services, as well as our health department, really made a difference. And to be quite honest, even the Department of Business Affairs in Chicago got involved and was helpful in producing promotional material to educate people that was actually targeted and that was effectively targeted. And I think that that was a challenge. Initially, in a lot of other situations, you don't always get that alliance. And I think that if we can see the business community, like our business community, came together very strongly and made a decision, on North Halsted, we were going to educate our consumers, we were going to protect our consumers, we were going to do what we could to vaccinate our consumers, and we were going to work with our local health partners to really try to make a difference. I think that really is probably a standard that the communities need to look at as a model, because it was effective, and I think it would be effective for the future. So I think that, again, from a government perspective, I think that we still are needing better allies, better communication, not top down like what Kate had referred to, where they're the masters of the universe. And to be hearing, well, masters of the universe, we need to have the ability to treat people in a time-effective manner so that we can continue to do the work that we need to do. There's still communication that's missing there, but it's a necessary, I think it's something that we need to evolve so that if you're going to try to address public health issues with alliances, the alliances need to be a two-way street.
And to that vein, and sort of pivoting, you already sort of broached this, Mark, in terms of allyship. So what can the business community, what can business leaders, particularly those participating in this session, what can they do to help navigate this? I'm thinking in terms of for their employees, in terms of sort of healthcare, in terms of allowing time off, other external factors in terms that can be helpful and as an ally to the community, and specifically looking at ways that they can be involved. I look at allyship in terms of my definition as more of an action rather than sort of particular words or and so what are some specific actions that business leaders can do for their employees, for their colleagues as relates to MPV?
I think that we saw it. The actions were transparent from, once we began to realize what we were dealing with and learning from the healthcare community, what they were actually seeing in the clinic, in the clinics, and we made that material very transparent. We had it on videos in my bars. We had it on posters virtually in every window. We had people, we did a vaccine clinic for employees on the street. We had people, of course, getting time off for illness. The missing element actually has been that where COVID, the government put resources and dollars toward addressing the needs. There really hasn't been an effective providing money toward the healthcare community to cover the cost of what we're dealing with here, and not even allowing them, from what I understand, to repurpose COVID dollars into addressing this crisis. So I think that that the community, to be an ally, actions that can be taken would be to communicate as a member of the public to our leadership, government leaders. We want to see these changes made. We want to see easier access to experimental medications that are being proven effective in the clinics. We want to see the ability to communicate, in a more timely and effective manner. We want to see restrictions on access to vaccines being, we want to see them moving in a more timely manner to try to address the needs of what's going on. So that, and we were doing that all along as a business community. We were aggressively lobbying and demanding that there be actions taken, that resources be brought to our community, that the national government move quickly toward that. And we did the best we could to make a difference.
I think those are all perfect ways of engaging and showing allyship. I think, one of the things is what people are doing right now is sitting and listening to a panel like this so that they're understanding kind of what we're talking about from a historical sense. They are taking that information and ingesting that to see what exactly can they do at their own companies, at their own businesses. I'm thinking that it also looks like highlighting, as Mark was saying, when there's partnerships, highlighting the partners in your local communities that are doing really good work around this. So uplifting those people and just saying, and this is how we are contributing to them, like either it's a monetary contribution if it's a healthcare organization, or, we've helped them, we have a activist day and we help them put up posters around or whatever that is. And I think, when we think about HR or people and culture department that are in all of our businesses and companies, like they're also to deal with health, right? This is all about making sure the people that work with us and for us are, they're alive, they're healthy, they're happy, they're able to engage with their lives and their work lives and their outside of work lives. And what does that do? Like, how can we kind of engage with our employees in a different way that passes on information to them? I know obviously there's always that issue of like, you don't want to, if you're not a healthcare organization, you're not going to just like send out newsletters every week about here's the updates, but there are ways that you can do newsletters, right? Like information gathering and passing on, again, through an HR department or something that allows people to understand what's happening in the world in a really clear and succinct way. We are involved with a bunch of lobbying efforts as our own business in terms of telehealth and moving health forward for this community in general. So there's always that piece too. But yeah, I think it's understanding the history here that is affecting this there and understanding present day reality of what is going on, and then being able to pass that information over to employees.
I think that also we can be, as business owners, truly caring about the well-being of our employees by not only focusing in on these crises. We actually were able to respond very quickly to COVID in terms of trying to help to vaccinate people, because we had a history of already vaccinating for flu. We had a history of already trying to protect our community on many levels. We have in our businesses people doing testing for different diseases and to be able to find, help identify people if they have HIV, to make sure that they're getting access to resources. We destigmatize disease. These are not, it's not the scarlet letter. People get sick. And to stigmatize is where we run into a mistake as a society. And I think that we just have to really take, as business owners, the initiative to give people the opportunity to get access to medical care. I have sent more people to Howard Brown long before I became on the board, forever, because I wanted to take care of my team, and I wanted to be a good owner and a responsible member of the business community. It's why we've organized in our businesses, we have brought the community together to get flu vaccines, to help reduce transmission of things that we deal with in our communities. I think that if all the business communities took more proactive actions to really protect their members of their clients as well as their employees, we'd have a healthier society.
We have about 2 minutes left. So what should people do if they have more questions, Kate, in terms of resources, on where should they go? Obviously, Howard Brown is a great
Howard Brown's great local, yeah.
You can go to the other organizations within your local municipality, but are there any other places to go?
I mean, there's the most updated, if you're like a data nerd and want to see trends and all of that, the CDC website has a lot that's going on globally as well as nationally. So that's some place that, again, people might want to go to. I love going there. And all the state Department of Health have their own websites that have links to specific vaccination sites. And, you can always, we have a library at FOLX Health that has updated articles all the time on what's going on and where we stand. So, yeah.
I think that one of the things that we need to just keep doing also is recognizing that people are getting weary of infections. They're weary of vaccines. They're just tired. And so we need to continue to even communicate in a more forceful manner, perhaps, to encourage people to take care of themselves and to remind them that it's a very simple process. Because the recent reports on the newest version of the COVID vaccine, for example, that the uptake is very low, and monkeypox, there was waiting lists, people literally wrapped around the block when the vaccine first became available. And now I know that there are slots sitting empty and people still need to be protected. We want to see them not get infected. And flu vaccine, similarly, the season's starting. And I just think when people hear the word vaccine, they're tired, and we can't get tired of protecting ourselves.
Well, all right. Well, thank you. Appreciate the discussion. I'll turn it over to Jenna.
Well, thanks, Mark and Kate and Garrett, for a really, wide-ranging discussion, but provocative all along the way here. I hope that for those of you listening, you got a little bit more information, maybe a little bit different perspective about ways that you can engage, be supportive, or get more information. With that, special thank you to our co-producers of this event, Chicago Innovation and StartOut, for your leadership in wanting to really, advance the public health discussion and also support the LGBTQ plus community. Thank you. We appreciate it and hope to see you soon at another Matter event. You can visit us at matter.health/events for some upcoming things. So thank you and have a great afternoon.